Unfortunately, while I do love CPR, I have a fair recognition that most of the CPR we're going to do is not going to produce a life at the end of it. And to some extent, that's okay. We can talk at some other point about like when to actually stop resuscitations and that kind of stuff. But, realistically, when you die, when your heart stops, most of the time, and we're talking 98% of the time, something like that, all told, your heart stops and your brain dies, and that's the end of it. Some of us have the recognition that when that happens, we wouldn't want resuscitation. We wouldn't want chest compressions. We don't want to be shocked. We don't want to have a big, metal hook shoved in our mouth, and then somebody come along and ram this hard plastic tube down between our vocal cords, and then live on a ventilator for the, next 8 months before you ultimately die of a terrible pneumonia anyway. There is that recognition out there. Some of us, when we go, we just want to go. And that can pose some interesting challenges in terms of relaying that to our EMS providers when that actually happens. So this is a talk of acronyms. And in the end, what we're talking about is EOL, or end of life care. You do only get, most of us really only get one chance at death. It happens exactly one time in everybody's life. And we can hope for the best, and hopefully we as EMS providers, we as emergency medicine folks, we oftentimes kind of walk on that line to start with, and it is our responsibility to make sure that we know what we're doing when we're not supposed to resuscitate somebody as much as when we are supposed to resuscitate somebody. So we're all going to die. The average death for a man in the U.S. happens around age 76, about 81 for women. A lot of the times it's expected, sometimes it's not. Heart disease and cancer are the number one, number two, and then unintentional injuries, number three, and then stroke goes down there a little bit, and COPD is kind of on the same lines as stroke here. But there's stuff that's waiting out there to get rid of all of us. Some of the time, we can expect that we're going to die sometime soon. Once you hit 72, you can kind of say, well, the chance is coming along here. At some point, it's going to happen. Maybe in the next year, maybe in the next 20 years. But you're closer to it than not closer to it. And so there are ways of communicating what it is that you want to do when your heart stops. If you would like somebody to try to resuscitate you versus if you would not, and how exactly you would do that. And that is largely regulated by what state you're in. It's a state law kind of issue. Now, the tattoo across the chest, while it is meaningful and does hopefully convey what seem to be your wishes when you got the tattoo, it is not actually a legal document. You have to have something essentially through your state government that allows an EMS provider to take that word that, like, oh yeah, he would not want chest compressions. So we'll talk about at least Ohio and Kentucky, because there are Kentucky people and Ohio people that are watching this now. Indiana, if there's somebody from Indiana, holler at us, and next time I'll try to add something about Indiana in there, but I don't think we've quite breached that market yet. And also, I just don't know about Indiana all that much. You got to talk a couple of terms. First, number one, there is this thing called Advance Directive. Advance Directive kind of broadly means do you have a form that shows your wishes in case something happens and you're not able to say what it is that you want. If you're awake and talking, you don't need Advance Directives because you're awake and talking, and provided you're not like severe advanced dementia or something like that, you can make your own decisions. It's when you lose the ability to make those decisions because of terrible illness, you're unconscious, you've had a stroke and you can't comprehend what's going on, or you can't talk, you can't convey those wishes because you're locked in or something like that. That's when advanced directives are out there. So broadly, advanced directives are everything. In some places, an advanced directive specifically means a legal piece of paper from the state. A living will generally is a legal piece of paper from, again, the state. Sort of the way that your last will and testament, you can have a will, but it's not necessarily a legal document. If you just write down, I want to give all my stuff to Jerry, and then sign it in Sharpie, that's sort of that may be your will, that may be your wishes, but it's not really a legal document. Whereas, if you had it drawn up by a lawyer and all that kind of stuff, then it becomes more that legal sort of thing. And this is sort of the same thing. You can write on a piece of paper, I would never want a feeding tube, and I would not want chest compressions, and then you sign it and put a little drop of blood on it or something like that. That clearly conveys what seem to be your wishes, but it's not really a legal document. This is a legal document. It's usually filed with the state itself. It talks about what you would want, and you had a terminal or in the event a terminal condition or in the event of imminent death. Would you want fluids? Would you want nutrition? That kind of stuff. Living wills are generally not able to be followed, we'll say, by EMS. This is kind of like overall healthcare stuff, but for the most part, we as EMS providers don't really follow living wills. We're not really able to do that. There's these things called power of attorneys or healthcare proxies or healthcare agents or surrogates or medical decision makers. And in this case, instead of having a piece of paper that will tell you what to do, there is a person that you have assigned to make decisions for you if you are incapacitated. And again, if you are awake and talking, even if you have a healthcare power of attorney listed, if you are alert and able to make decisions, then that person doesn't make decisions for you. I could appoint, Stan as my healthcare power of attorney, but if I have capacity, then the power of attorney doesn't really kick in. Stan can say, "Oh yeah, pull the plug on him," and I say, "No, don't you do that." Then my wishes are still there. Whether or not things like DNR orders supersede the power of attorney stuff is dependent on your state, and we'll talk about it in a little bit. But this is a person that if you can't make decisions, if you lack capacity, that this person can make those decisions for you. And again, that can vary a little bit state to state depending on what power that person has, or if you have a if you have a legal guardian that's appointed by the state, then that's another different story altogether. We're just talking definitions here right now. We'll get into the stuff here, the actual stuff in just a minute, but you got to lay all this groundwork. There's this other stuff called the post or the pulsed or the most, and these are orders for scope of treatment or for life-sustaining treatment. What these are, this is a form that has doctor's orders on it. This is filled out by a doctor. It's really not supposed to be like handed to the patient and say, you just check on here what you want. It's supposed to be a doctor, generally speaking, looking at it, talking to you, and then filling out this form. So that you have orders that are in accordance with your wishes. And this generally has a DNR thing on the top of it, but it also has things like, would you want antibiotics? Would you want a feeding tube? Would you want artificial hydration? Who filled this form out? That kind of stuff. We'll again talk about it. But these are essentially doctor's orders about what you do here. And then there's this last thing, the DNR and the EMS DNR. DNR, in this setting, in some places, the patient fills out the DNR form and says, I don't want to be resuscitated. In some states and some localities, it may be different about whether or not you can have a DNR form from a nursing home carry out into the EMS setting, or if you have to have an EMS-specific DNR, like in Kentucky. So in Kentucky, you print off the DNR form, and then you sign it, and you either notarize it or you have it witnessed, and then EMS honors that form. But in Kentucky, if you have the Baptist Health DNR form, that doesn't necessarily mean that EMS won't resuscitate you. Again, wishes are there, but legal document is a little bit different. So DNR, the do not resuscitate specifically, generally covers whether or not you get intubated, shocks, epinephrine, chest compressions, that kind of stuff, but not necessarily whether or not you get a feeding tube or something like that. That keeps it clear. Now, some places screw this up, Ohio, and they make it too complicated, and then all of a sudden it's more like that most form than it is a clear DNR. What do I do if this person's heart stops kind of thing? Again, you can look up, I think this is from the Pulsed people. They all have different layers of complexity to them, and you can look this kind of stuff up and see it. But there is a difference between the legal document that is the Advance Directive and like the medical order sort of thing, and in who can follow it and what you should actually do with it and who can make changes with it. But again, of course, it's different state to state. So let's talk about Ohio to start off with and what the DNR stuff is in Ohio. I work in Ohio. I live in Kentucky, but I work in Ohio. And it's interesting to compare and contrast the differences between the ways that you can be a DNR or convey your wishes state to state, even just crossing the river. So here's the Ohio DNR form. Let's cover that. There's a living will form that you can do, but again, not really honored by EMS, or not really honorable by EMS per se in and of itself. The DNR form is honorable by EMS, though. Ohio changed theirs in, I think it was 2018, if I remember correctly. They said that they clarified a few things, changed the form. If there's an old version of the form that's properly signed, though, you can still honor that old version of the form. In Ohio, the form is filled out by a doctor. Or it's supposed to be anyway. It requires the signature of a doctor or of the physician assistant or the PA. You can sign it if you want, but this is an order from a doctor, essentially. When you look down the form, that's the top. The second part is whether or not you wish to be DNR comfort care arrest or DNR just comfort care. Now, the difference is supposed to be what they say. Oh, well, they're both the same thing, but it just matters when it kicks in. So if they have DNR comfort care arrest filled out, then it is supposed to be when their heart stops or when they stop breathing. That is when we say, all right, we're done. We're not doing anything else after that. But up until that point, you do pretty much everything. The DNR comfort care part is supposed to be as soon as you sign that, ka-chunk, life-saving care kind of ends. But you can still do other stuff. So then you can start to see how it gets a little bit funky in here. Here's what, again, the rest of the form says as you're moving down here. You're supposed to, even if the person is a DNR, whether they're in arrest or whether they're not in arrest, you're supposed to do an assessment, perform medical care, potentially clear their airway. You can put them on CPAP, BiPAP, all that kind of stuff. And, of course, if they're a comfort care arrest, then that won't really make a big difference because you would just, let them continue to arrest, essentially. You can start an IV for pain or hydration, but not supposed to be to prolong death. So I'll get into it in a second. Sorry, I can't help but get on my soapbox about how dumb this is. If possible, you can contact other people, like hospice, if you see these folks. What you're not supposed to do if they're DNR, this is a more clear part, and thank God they say this at least. You're not supposed to perform CPR. Okay, makes sense. They're DNR, right? Don't resuscitate. Don't give resuscitation medications with the intent of restarting the heart or breathing. Okay, avoid the epi. Got it. No problem. Insert an airway adjunct, defibrillate or pace, or initiate continuous cardiac monitoring. Now, again, theoretically, under what all this stuff says, that means that you wouldn't put somebody that is DNR comfort care on continuous cardiac monitoring, like 4 leads on them, because I guess you don't care. Now, that's not the way that most patients interpret that, I think, because most patients, when they get sent to the hospital, they'll still say, yeah, I would want to be on the monitor. Can we start an IV to give you some fluid because you're really dehydrated? Now, if they're terribly dehydrated, they're going to die, but it says here you can give them fluid to rehydrate them. You have to kind of interpret it, and here's the best way that I can interpret it from all the screwy stuff that's out there. If the patient is a DNR, whether they're DNR comfort care or DNR comfort care arrest, if they're comfort care arrest, you can treat them just like any other patient would be up to the point that they stop breathing and their heart stops, and then you let them go. For the DNR patient otherwise, that is just like DNR comfort care, you should do an assessment. You should try to figure out what's wrong with the patient. You can get an O2 sat. You open their airway. If they're choking, you reach in there and you pull the hot dog out of their throat. That's definitely okay. You can put them on CPAP or BiPAP. You can get an IV on them. You can give them pain medicine, antiemetics, hydration, and to some extent, they say you're supposed to treat infections. So, if you happen to work in a hospital as well, you can give these folks antibiotics, it seems. Basically, anything that's not imminently fatal, and treatment would make the patient feel better. What you're probably not supposed to do is, again, do the resuscitation stuff, but do the stuff like pressors or send them to the ICU. Although, again, you talk to a lot of patients that have DNRCC marked on there, and they would say, yeah, I want medicine. I don't want to die. I just don't feel good right now. I just want to feel better. Worst case scenario, you talk to the patient and you figure out what they would be okay with if they can communicate with you. because otherwise it is a little funky. And I wish I had more clarity on it. But when you look at what Ohio Department of Public Health puts out, here they say the patient's got a urinary tract infection, a high fever, and requires medical treatment and needs a DNR comfort care. What do? They say, well, you treat them, of course. Or the family is supposed to advocate that the patient get treatment, of course. But then in a very similar scenario here, you have the patient has pneumonia and they might need to be intubated for a short period of time. And then, maybe actually, what if the patient is still a comfort care? Can they still be intubated? I don't know, man. It gives you too many options. You got to just ask the patient. In the end, you should just ask the patient, ask the family, is this what the patient would want? And you can do that in the field too. He's marked as a DNR comfort care, but he clearly is about to die, or something like that. If you ask them, like, would you want this? They can say, yeah, I would want that. And then you do what the patient asks. All right. Sorry, again, getting on a little bit of a soapbox there because it frustrates me to no end because I think we don't explain this stuff to the patient, and I think the families often don't understand what it is that they are signing up for. I think most of the time they meant to say, yes, comfort care or rest, but do everything else up to that point. Because if they were just comfort care, they would probably just be in hospice. Anyway, did it again. Let's look at the actual Southwest Ohio protocol to see what you would be doing in these cases. In the end, just to jump on it one more time, just ask the patient. Ask the patient, ask the family, what would they want? Do they want to go to the hospital? Do they want X, Y, or Z? What does this mean to you all, if there's any question about it? And you can go ahead and do everything short of like intubating and shocking people, generally speaking, to say we are relieving suffering here. Don't be afraid to give these folks medicine if it is going to make them feel better. Okay, anyway, here's the Southwest Ohio protocols. Just to hit these a little bit, you have to have a valid DNR, which is the DNR, the Ohio form, essentially. Special note, again, it has to be signed by the doctor. It doesn't necessarily have to be signed by the patient. A DNR signed by both parents of a minor child or by the spouse of a patient in a terminal condition who is no longer to make informed decisions, and signed by 2 witnesses may be honored, which, again, the whole thing actually just says it needs to be signed by the doctor, and the patient's signature is actually not all that important on it. DNR set forth in a long-term care facility. Medical records shall be signed by the attending physician and dated. And so, yes, you can have a DNR form from, Silver Springs Nursing. I don't know if that's a nursing home or not. Sorry if it is. But you can have a nursing home DNR that says the patient would not want to be resuscitated. And if it's signed by the attending physician and it's dated, then that's clearly their wishes. And just because you're leaving the hospital, that doesn't mean that you shouldn't follow it. So they can have the official one. They can have a facility-specific one. Each one clearly conveys the patient's wishes. And just because you leave there doesn't necessarily mean in Ohio that you're not going to resuscitate this person afterwards. In the event that a DNR is presented that is neither of the above, meaning it doesn't seem like it's filled out properly, or there's some question about it, or something like that, you should contact medical control. Or you should talk to the patient's family physician or whoever happens to be on scene with them there. You need to talk to a doctor and get this figured out. If you have what looks like kind of a funky filled out DNR, but it's very clear exactly what the wishes are, but you're just not sure if this is a legal thing, there's no need to do CPR while you're trying to sort that out. If the intention is clear there, you don't necessarily have to wail on this guy just because his name, the wrong date was on it or something like that, if it seems okay otherwise. If there's any doubt, again, talk to get my head out of the way there, physician who will verbally authorize that is okay. And that's the easiest kind of way to do it. So if you look at it and you think, this looks really sketchy, I got to talk to the doc about this one, then yeah, you should do resuscitative stuff. If you look at it and say, well, it looks like it's filled out wrong, but I don't have any doubt about the validity, or I don't have any doubt about this is the patient's wishes, then it's okay to still call the doc, confirm that, but you don't have to do CPR. Make sense? Do what seems to be right for the patient. And then one thing in Ohio, and this is really in most places, a DNR would not be honored in a pregnant patient. Where withholding CPR would terminate the pregnancy as probable the fetus will develop to the point of live birth if treatment is provided. So if there's a possibility that or even probability that the baby will survive, even in mom, if mom comes back with treatment, then the person's not supposed to be a DNR. You could argue about viability and like what the downstream effects really are, and the likelihood that mom is probably not going to survive, so baby would not. But make it easy and say if they're pregnant in Ohio, they're not supposed to be a DNR. You are supposed to do everything because you got to worry about the baby, and you don't know what might happen to the baby. So if there's a possibility, you should go ahead and do CPR for these folks, and that'll come up here in a minute. If there's any, again, as we kind of mentioned before, there's any doubt about the authenticity of the DNR, then you should do CPR and document the reasons for not complying with it right away, and try to get a hold of the patient's family physician with your online medical control, whoever it is that you got. In the end, again, if there's question about it, do what seems to be right, generally speaking, and then document why you did that. If you if you identify a patient who has a DNR after you've already started resuscitation, maybe you've given him a bunch of drugs, maybe you've shocked him, maybe you've done 20 minutes of CPR, and maybe you got him intubated. What do you do when you find, the daughter shows up with a DNR form that looks good? Then what you actually do is say, okay, we've done the stuff up to this point, we've now identified the DNR, we're stopping. And you stop, you leave the person, if they continue to be in arrest, if they continue to be pulseless, you leave lines and tubes in place, you talk to the coroner or to the police, whatever your local jurisdiction says to do, and you leave it there. The one caveat is that if that happens and then you have actually restored cardiac rhythm and then they show up with the DNR, well, now the patient isn't in arrest anymore, and so they're just like any other patient. You can't really leave an intubated patient at home, so you kind of got to take them to the hospital. Generally speaking, if they get ROSC, you should probably take them to the hospital unless they are, a hospice patient and the hospice nurse is on the way to help take care of them and attend to their needs and that kind of stuff. And then you still may need to take them to the hospital just to avoid suffering and pain and stuff that's caused with it. So if you find a DNR form after you've started, if they're intubated, leave them intubated. If they have a pulse, you should probably take them to the hospital. If they do not have either, then leave things as they are, slow fade, condolences to the family, call the coroner, call the police, whatever it is that you normally do for folks that arrest on scene. All right. And you are actually supposed to take the DNR, like a copy of it or a photocopy or something like that. You are supposed to scan that in with the patient's medical record. One last thing on Ohio real quick, and then we'll take a quick break. What's the difference between the CCA and the CC? We talked about that already. If you are CCA, it's supposed to be just DNR like we always think of it. If it's CC, from an EMS standpoint, we can generally do most of the stuff that we would normally do because most of it is going to be relieving suffering. Probably shouldn't give somebody who is DNR CC pressors. Probably shouldn't put them or shouldn't try to pace them if they're bradycardic. Shouldn't provide a lot of electrical therapy, that kind of stuff, even if they have a pulse and they haven't arrested yet. Those are kind of the big things I can think of with it. If they are choking on a hot dog, you get the hot dog out of their throat, though. If they are gagging on their own, secretions, then you can suction their secretions. If they need BiPAP, you can put them on BiPAP and help them breathe more comfortably. That stuff is okay. The one other thing that comes up from time to time is what do you do if you have a bunch of different forms? You have a DNR form, they have an old living will form, you got 3 people that all seem to say they're the healthcare surrogate, and then you have a new facility DNR form as well. Which one kind of takes precedent? What is out there? There is a series of kind of hierarchy with this. So if you have a living will, it's supposed to be more powerful than your power of attorney. Your wishes, generally speaking, are more powerful if they are clearly conveyed. Those take precedence over what somebody else's decision for you would be. even though they're your decision maker. If you have a DNR form spelled out, your power of attorney is not supposed to be able to kind of counterman your DNR form if you filled it out. Now, if the power of attorney filled it out, then they can change their mind. That's kind of whatever. But if you've made your wishes clear, that is supposed to override the power of attorney's ability to make you not a DNR, essentially. If you have a new living will or a more recent living will or a more recent DNR, that's supposed to take precedent over the old DNR. So even though you may have had one that said, I'm a DNR comfort care to start with, and this one has DNR arrest marked on it, you're supposed to follow whichever one is the most recent. And this actual Ohio statute says the same thing I just said. Your living will or your clearly defined wishes override the power of attorney's ability to make you continue to live if those are correctly filled out and there hasn't been a substantial change. Your power of attorney, if they signed a DNR on you, can change their mind as if it's the power of attorney that signed it or that initiated it, essentially. The new living will is more important than the old living will, and you should follow whatever the most recent document is, because really the old one should just kind of go away. And then same thing with DNRs. New DNR is better than the old DNR or old living will, something like that. In general, something you signed is more important than something that somebody else signed, and then a new order is more important than the old order if you forget anything else. All right, let's take a break.